Welcome, everyone. Thank you so much for joining us tonight. I'm going to hold off just a minute while our platform's letting everyone on and give you all a chance to join us. Feel free to use the chat in the meantime to give us a greeting, say hello, let us know where you're tuning in from tonight. We would love to hear from you. You will notice as you're joining, your cameras are automatically off and your mics are muted. You will have that feature on the whole time, so you won't be able to see yourself. You won't be able to turn on your mic and ask questions, but please feel free to communicate through our chat tonight, and we will be started shortly here. Hello, hello. Thank you all. Welcome. I love seeing these greetings coming in through the chat. We have people coming in from all over. Welcome. We'll be started in just a minute here. We're just letting our platform let everyone in. Wonderful. Hi, everyone. South Carolina, California, Detroit, New York. I love it. Welcome, welcome. Well, thank you all for joining us. I'm going to go ahead and get started. Welcome to tonight's webinar, Managing Chronic Disease, the Mental Health Connection. My name is Jackie Zimmerman. I'm the Public Education Associate at Mental Health America's National Office, and I'll be moderating tonight's webinar. I have a few notes for you all before I introduce our topic and speakers for tonight. This webinar is being recorded and will be emailed out to all registrants within 1 week. We currently do not offer CEUs, but we do have a certificate of attendance that you can fill out a form and request one of those, and it will be emailed to you within 1 week. I'll post the link to that form in the chat here shortly, and that will also be included in your follow-up email. I am so excited for this session we have ahead. Here at MHA, we're extremely excited to partner with NPF, the National Pancreas Foundation, to expand our work, education, and understanding of the connections between chronic disease and mental health. At Mental Health America, our work is really driven by commitment to promote mental health as a critical part of overall wellness, including prevention services for all, early identification and intervention for those who are at risk, integrated care, services, and support for those who need them, with recovery as the ultimate goal, which is what led us to our partnership with NPF. We really want to provide education for those who are in the mental health field, working within chronic disease or chronic pain, and also for those who are living with chronic disease or chronic pain, to really provide additional support, education, advocacy, and research. And so that is what brings us all here tonight for this very important discussion. Which leads me to introduce our speakers. With us tonight, we have David Bakelman, CEO of the National Pancreas Foundation, Nicole Hemingway, CEO of the U.S. Pain Foundation, Dr. Wasif, Division Chief of Gastroenterology and Hepatology at Banner University Medical Center, Matt Greiner, NPF Pancreatitis Patient Advocate, and Dr. Ulrich with Mendenfarts, who's focused in cardiopsychotherapy. Welcome, speakers. We are so grateful to have each of you with us tonight. Throughout our session, you'll hear from each of these individuals on their respected area of expertise in regard to the mental health and chronic disease connection. So first, I'll pass it along to David Bakelman to start off with some background on NPF.
Thanks, Jackie, and welcome to our attendees as well as our panelists to Managing Chronic Disease, the Mental Health Connection. Again, thank you to our panelists and all of our attendees from all over the country for attending. And I also would like a special thank you to AbbVie Pharmaceuticals for providing the educational grant for this 4-part webinar. The National Pancreas Foundation is the only national foundation and charity in the entire United States that impacts all forms of pancreas disease, meaning pancreatic cancer, pancreatitis, pediatric pancreatitis, and FCS. This initiative and this webinar and this partnership with Mental Health America is so important, and we've been working probably for around 18 months to get this off the ground. We know not just with pancreas disease, but overall chronic disease, when someone suffers from chronic disease, it's not just a physical impact, but the impact on one's mental health. And that's why we have this 4-part webinar series. Also, it's not just for those impacted by chronic disease, meaning the patient, but also the impact from a mental health perspective on caregivers, families, and additional community relationships. More and more research is showing, clinical research is showing that chronic disease and illness has social and emotional development issues on the entire family unit that I just stated. To effectively treat the individual, we must look at the whole person, which means examining the connections between chronic disease and mental health concerns. This is a major component of not just this evening, but the other 3 webinars throughout the year. We feel really strongly with the relationship between the National Pancreas Foundation and Mental Health America that will positively be able to impact the mental health concerns of chronic disease, not just tonight, but going forward. Jackie, back to you, and thank you again.
Absolutely. Thank you so much, David, for that great introduction. We are going to hand it off to Dr. Wassef to start us off, and I am just pulling up your slides here.
Thank you, Jackie. As we go through the discussion and the presentation, you'll see that I'm echoing a lot of what David has just said. I've been interested in pancreatic disease since I finished my GI fellowship back in 1993. So it's been a few years. And my area of research has been to look at a way to evaluate the quality of life and the impact of pancreatic disease on the quality of life. Next slide, please. Chronic pancreatitis, as you all know, is not a rare disease, and these are just some of the prevalence of chronic pancreatitis in various countries. Next slide. This is an old study from 1993 looking at the natural history of patients with chronic pancreatitis. The most common symptom that these patients have is pain. They also can develop diabetes because that's where insulin's made. They also can develop diarrhea because of malabsorption of food because of pancreatic insufficiency. But pain is the major feature. Next slide. And as David had said, the pain that the patients get with chronic pancreatitis is going to impact a lot of different things. It's going to impact their mental function, and we'll talk about that. It will impact physical function, social function, as well as role function. Next slide. When we talk about mental function impact of chronic pancreatitis, because of the chronic pain, it can alter sleeping habits, it can lead to anxiety, it can lead to depression and suicide. Now, the focus of my research was to study the impact of chronic pancreatitis and to develop the first and only quality of life instrument that is specific for chronic pancreatitis. As we did that, and as you will see, mental function is one of the components, but there are other components that were there. Next slide. So we'll discuss in the first part is the instrument development, and that comes in 3 parts. The generating of an item pool. This is from focus groups that we've had with patients with chronic pancreatitis. Whenever you develop an instrument, you also have to validate the content by asking experts in the fields, physicians and patients, about what they think of the item pool, whether it's sufficient, whether we missed anything, or whether it has items that are not relevant at all. And then finally, and most importantly, when you're evaluating an instrument, you have to do psychometric evaluation, where patients are actually taking the instrument, the evaluation itself, and trying to see how coherent it is, how relevant it is to their quality of life. Once we do that, we're going to see how it applies in other places. And what I mean by places is just places in the United States. This is something that interested other countries, other cultures to along with, because they also saw the same impact that David had mentioned and that Jackie had brought up at the introduction. And then finally, we're going to close by talking about some future directions that we are doing with this instrument. Next slide. So generating the item pool, as I said, we had focus groups as well as person interviews to try to get from patients with chronic pancreatitis what they think the impact of the disease is on their life. So we started with 51 patients from our pancreatitis clinic who met the inclusion-exclusion criteria, basically to have chronic pancreatitis and to have no other severely chronic disease that would impact them. And although we started with 51 patients, we were able to only get 10 patients in the study. But in the study, we had actually focus groups, and we had interview sessions. And the total number is not as important when you're doing qualitative research, which is what this is, as what they call saturation. And by talking to these patients, these 10 patients, we were able to reach saturation. What that means is by the very last session that we had, there were no new items that were brought up as items of concern. And this was published in SAGE back in 2014. On the next slide, you're going to see some of the things that came up in the discussion focusing on the mental impact of chronic pancreatitis. So as far as the emotional function, and this is out of 10 patients, so 7 patients had issues being upset with the number of pills, the creon, the enzymes that the patients were using for their to help get enzyme therapy. 6 out of 10 patients just had stress for a variety of reasons from the chronic pancreatitis, depression in 3 patients, frustration about food they cannot eat, embarrassment, angry about the condition, fear, losing dignity from diarrhea. And the very last item you have there is actually very, very important. We don't think of suicide in chronic pancreatitis, but the chronic pain, as you see, there is depression. The chronic pain can bring about suicide as well. And that came up in the discussions that we had with the patients. So clearly, there's a lot of impact of chronic pancreatitis on the patient's quality of life, on their emotional, and on what's going on with them. Next slide. So once we've done that, there's a lot of different items that came up: physical function, emotional, social, role function, general health. One of the features that came up in this instrument, there is also an economic impact of chronic pancreatitis on the patients. You don't usually see that in most quality of life instruments, but we saw it here. There was also spiritual fun stigma. Next slide. So we use these items to change them and to put them into questions that patients would have, and into what they call a Likert scale. In other words, you can have 4 choices or 5 choices to evaluate the patient and see how they feel about the different items. We had the 5 domains. That was the instrument: physical function, social, role function, economic, general items, and most importantly, emotional function. There were 10 items that we included. Next slide. The content validation of the item pool is to try to identify if there was anything that we missed, or if it was things that were too redundant or had nothing to do with the quality of life impact of chronic pancreatitis. So that was a separate study. Next slide. In that study, we wanted to identify items that we had missed and items to validate or invalidate the rest of them, as I said. We started with 35 experts in the field, and we obtained their names from society membership rosters. In reality, although we started with 20 of those 35 who agreed to participate, in reality, only 7 really completely filled the content validation tool. And when we talked to these physicians and these doctors who were taking care of these patients, including psychiatrists, including nutritionists, including pancreatologists, of the 40 items we had identified, they thought that 23 only were valid, 8 were unrelated, and 9 were redundant. It is important to note that those 23 items included all of the items that we mentioned for emotional impact by chronic pancreatitis. Next slide. So we removed the 17 items, went down to 23. And when we did the instrument at that point, they recommended having a 5-point scale rather than a 4-point scale. The reason for that is if you have a 4-point scale, you're forcing the patients to say that if they're feeling well, are you feeling better than before or less well than before? But if you have a 5-point scale, you can add the item, they're feeling as well as before. In other words, there is no change. So that was one of the recommendations. And one of the other recommendations that was made by the expert panel was the impact of chronic pancreatitis on their sex life. That was not identified from the focus groups, but that was something that the physicians and the experts in the field thought that there was also room for that as a very important item impacting patients with chronic pancreatitis life. Next slide. Then the last part was to test the instrument and see what people thought of it. Next slide. So this was done by getting 11 pancreatic centers from throughout the country involved in this. Again, we use the same parameters, inclusion, exclusion criteria, and this was published back in 2016. Next slide. This is a list of the places that were at the time. I was at UMass Memorial in Worcester. This also included Indiana University, University of Alabama, Pittsburgh, big pancreatic disease center, Wake Forest Digestive Health in Mississippi, MUSC, St. Louis, Cleveland Clinic, Stanford, and New Hampshire, Dartmouth. So we had 175 patients from throughout the country involved in this study. And on the next slide, we see that, next slide, please, that 16 of those patients had to be excluded because they did not complete the instruments. When we looked at the two groups, there was really no significant difference between them. So we're not really biasing our sample size. Next slide. The most important thing that we saw is the only difference in terms of the quality of life between the different patients was the pain medications used, the number of pain medications used. All the other parameters did not seem to make any difference between the patients, so that allowed us to combine the results. Next slide. And there was 6 items that were removed because they are either completely unrelated based on the psychometric evaluation, or they were redundant because they were too high correlation. And we ended up with a reliability score. Anything that's over 0.85 very good. So this was 0.915, and the instrument ended up with 18 items on it. Next slide. So there was physical function, nausea, vomiting, pain, sleep, diarrhea. There was social function being impacted. That was part of the instrument. And that related to activities with families, activities with friends, activities as parents, ability to work, and sexual activities. Next slide. But here is really the most important piece, the emotional function, anger, depression, frustration, and stress. These were key parts that were being impacted by patients with chronic pancreatitis. Other items included overall health, money situation. Again, another feature that's not usually in most quality of life instruments, but between healthy foods, between expensive medications, it really is impacted by the chronic pancreatitis. But I'm going to go back to the emotional function. That is clear. The correlation between them is very, very high. And that's just another measure of how much emotional function is being impacted by somebody with a chronic condition, chronic pain, like in chronic pancreatitis. Next slide. So I said that the instrument was developed and we were looking at a lot of different things, but obviously emotional is one of them. But the interesting thing that this was developed in this country. And once it was developed and published, I think it was around 2015, 16, there was a lot of people that were very much interested in it because they shared the same thoughts that Jackie shared and that David shared with you at the beginning of this discussion. Next slide. This is just a test that we did looking at control population, looking at chronic pancreatitis. And you can see from the bar diagram, the higher the numbers, like 90 plus, patients had relatively good quality of life, 50-ish chronic pancreatitis. Chronic pancreatitis patients had more severe impact on their life than patients with Crohn's disease. And Crohn's disease is something very chronic that people see and look at and think that things are really, really bad. Well, guess what? Chronic pancreatitis is even more severe than that. And I don't think that that's appreciated as much. Next slide. This is a bar diagram comparing that first slide that you just saw to the chronic pancreatitis smokers and non-smokers. Obviously, smokers do not do as well in their quality of life as patients that smoked and quit or non-smokers. So 50 versus 60. Next slide. So future directions. Next slide. One more. One of the things that we wanted to do is we looked at quality of life and we got impact of quality of life and chronic pancreatitis on the patients as a whole. But to talk about targeted medicine, people start to focus on things so that they can focus on certain treatments for patients. One of the next projects that we have in mind is to identify which domains is impacted in different patients. Is it the social function? Is it the mental function? Is it the physical function? And identify how we're going to approach it. So if it's the mental function, you're going to take a different approach than if it's a social function or if it's the physical function. And I think by doing that, we can target the approach to different patients because not all chronic pancreatitis patients are going to be impacted the same way. And I think that that would be the next way to focus on it. Now, one of the things that I mentioned before and did not really show you the slides for is that what other places were interested in using this instrument. So after the instrument was published, we have received email and contacts from Czechoslovakia, from the Deutsch group, and from China to interpret these and to validate these instruments in their own cultures because they thought that that was something very important that they needed to do. We also received communications from the FDA. We actually presented this to the FDA in February 2020, right before COVID hit, to discuss this as an instrument to evaluate different pain medications and different management tools available for patients with chronic pancreatitis. So this is also being regarded as a way to quantitatively evaluate patients with chronic pancreatitis. I think even though he did not start by talking about emotional factors in chronic pancreatitis, clearly it is something that is strongly impacted by the disease, by the pain, and it's something that we need to address whenever we're dealing with patients, as Jackie and as David had mentioned at the beginning of the talk. I think that's my last slide. This is just thank you to all the people that were involved in the studies and the research.
Thank you so much, Dr. Rosick. That was really a really great overview, and it's so important when we're talking about these topics to get that quantitative approach to really see the data behind, you know, these discussions that we're having. And next, we kind of get to hear from that qualitative side and that lived experience. And so someone that we have with us today is Matt Greiner, who will be sharing his own personal experience with pancreatitis and kind of echo what that looks like through his life based on all of these findings and statistics and things that we were able to collect through Dr. Wassif's school. Thank you, Dr. Wassif, and welcome, Matt.
Thank you, and thank you all for this opportunity. It's an honor and a privilege to be able to be here and sit here feeling victorious in a sense and share being on the other side of the mental health struggle. Like most of you watching that deal with this and other chronic diseases. It is it's a horrible experience. I know for me, I did not roll into this pancreatitis diagnosis with the best mental health and physical health, and I had awful habits, and that's embarrassing to say because I was senior and I was in the military, and I was a senior enlisted. I knew better. I knew all the things that I was supposed to be doing for my health, and I was not doing them. And when I was at we know now that I have idiopathic pancreatitis, and we have done test after test, and we haven't been able to pin anything down as a particular cause. But I do know that I helped contribute, in my mind, I know that I helped contribute to getting to where I was. And, with a diet of pizza and burgers and beer every night, which I was badgered for being an alcoholic. I claimed I only drank 2 drinks a night. It didn't matter. They wanted to pin it on alcohol. And that there, the getting blame about the disease and receiving that is so hard. But yeah, I know that looking back, there was an element of responsibility in eating myself into a very unhealthy position. But I woke up one day with the worst pain I could ever imagine, the nausea, the vomiting, experiencing everything that's already been on these data charts. And I had no idea what was going on. And it wasn't handled well at Coast Guard Medical. That's, we're trained. That's for the first place we got to go. I was sent to the hospital where it was not handled well. I was given an ultrasound and sent home. Meanwhile, while I was getting that ultrasound, every 2 minutes I had to get up and throw up. And I was just sent home, and it couldn't, this never comes at a convenient time. And I was in the middle of a transfer from my unit in Oregon to a different unit in Seattle. So we had movers at the house, and I had to go back to the house. All the furniture's gone. There was an air mattress in a spare bedroom. And I was writhing around for about 6 hours waiting for them to finish. And then I told my wife, I'm like, we can't take this anymore, or I can't take this anymore. She drove me back to the hospital, and third time was a charm, and they diagnosed me quickly with just the lab test. We know the drill. You get your lipase checked, and my lipase was super high, and they confirmed pancreatitis. And I had no idea that my life was suddenly turned upside down right then and there. And that was in 2014. Like I said, I was in the military. I was in the hospital for a week. It was awful. The highlight was that my doctor let me have my dogs in the room with me. So it was amazing to have them. They were way better than the opioids for helping me out. And if you are a patient, work with your doctor to see if you can get that, if you have some awesome dogs. But I transferred to my next unit, and this is, like I said, the mental health struggle was there before the pancreatitis. I was in just 20 years of incredibly stressful jobs and terrible coping mechanisms, and just continuing to grind away until my body just kind of exploded on me. But at my next unit, there was the constant pressure of, when are you going to get better? When are you going to get better? I don't understand why you're still sick. And that was incredibly stressful. And I knew that I was going to lose my job, my well-being, if I did not start showing up to work. And the other thing that didn't help was when I went on opioids that day in the ER, I didn't come off for 3.5 years. And so I'm trying to go into this new unit and be the leader. And it was, again, we've mentioned this, embarrassing and shameful. And I felt, all the things, just guilty that I just felt sick, dumb, and lazy. And with the constant pressure and me trying to pressure my doctor, and I saw other doctors pressuring them for information that they didn't have, or it seemed like a mystery to me. I couldn't fathom why. I'm like, doctor, I don't understand why I just am still in constant pain. And The answer I got 9 times out of 10 was, well, the pancreas is a very complicated organ, and there's only so much we understand about it at this time. And I would get that same answer like it was a cue card. And that was horribly frustrating because I'm going to the system to receive the care because I feel like I'm dying, and I actually kind of am. And I feel rejected by the very system that's there to try to help me. And so that just compounds that mental health struggle of that isolation and feeling alone. And, I was accused of being a drug seeker all the time. I had a doctor tell me to my face in Seattle that I was a drug seeker and proceeded to quote all these statistics to me to my face while I was on the table or on the bed in the ER. She said, I'll check your lipase anyway. She came back a half hour later, profusely apologizing. So I at least got that. She said, oh my gosh, I can't believe this. She said, I'm so sorry. And she immediately had to dilaud it. I mean, you all know the drill. But again, the guilt, the shame, it's like you did not ask for this. And you're also trying to get relief from the most mind-boggling pain and god-awful experience that a person can possibly imagine. And for me, in my situation, it just got worse and worse. My hospitalizations got more and more frequent because of the stress. And by the end of 2015, they wanted to take my pancreas out, put pain implants in and all that. But something inside me is like, no, 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 no. I just refused. I was medically retired from the Coast Guard. It was devastating. I couldn't hit my 20-year mark. That hurt. But it's all good. And but I kept trucking along, and I was just degrading into an opioid nightmare. And it was destroying me and my relationships and my mental health even further. 2017, I started going into kidney failure, and I had a come to Jesus moment. And I just knew I needed to go to rehab. I was scared to death, but I put myself into rehab. Did not know what Suboxone was and didn't realize it was just a replacement therapy, but I got an amazing Suboxone provider. And when I was out of rehab, and we worked for 6 months to get me tapered off opioids, and I have been daily clean, as I call it, ever since 2017. And that's been amazing. And little did I know that those stupid pills were actually making my pain worse. They were exacerbating everything here, but I started reading about how certain opioids cause these sphincter rhabdoidi spasms and all that. And I'm pretty sure that was going on in my case. And it was, again, devastating. The treatment is just furthering the situation. But in 2018, I was like, you know what? I got to take control over my health because my life was getting stolen away from me. And I decided to start to fight back, and I started to exercise and push myself hard. I got into these endurance events with GoRuck, and just made a complete turnaround with my health. I was still dealing with these symptoms, but when I talked to my doctors, I'm like, just tell me my pancreas isn't going to explode if I do X, Y, and Z. And they're like, no, just stay hydrated. So I did that, and I'd be like, oh my gosh, I can't believe I was able to accomplish walking at the end of the street, and the next day walking to the next street over. And I just kept at it. And my wife and I ended up moving to Colorado in 2020. Mostly we were living in DC just to get away from all of that nonsense. We're out here. Another thing was to get access to the medical cannabis. It's been amazing. It's not a miracle cure. It comes with some caveats, and use at your own risk. Be careful, but I highly recommend it. It's done wonders for me. And since I've been out here, I've quit gabapentin and what else? The triglyceride medication, the nausea medication, and I even quit antidepressants after 11 years. And I feel better than I ever have in my entire life. And to the point where when I was coming off the antidepressants, I was going through a horrible suicidal rebound episode. And I put myself through a grueling workout regimen because I didn't want to be another veteran suicide statistic. And I fought with everything in me to just keep that from happening. And what I ended up doing is I started climbing 14ers, which are mountains greater than 14,000 feet. And I just kept grinding and pushing. And over the past 2 years, I've climbed 50 of them. And one of the last ones I did was a double 14er, and I climbed 2 in the same day. One was for mental health, And the other one was for victory over pancreatitis, and because we're climbing all these mountains that nobody sees but us, and we got to celebrate those wins and do the biggest thing that we can within our power, to just so we don't let this pancreatitis win, And when I say within our power, if walking down the street is your mountain, do that. If having a tough conversation or getting a therapist is your mountain, do that. And those are the things you got to do and celebrate, because that's what keeps us motivated and keeps us alive. And aside from that, just my faith in Christ, who makes all my suffering worthwhile. I'm just completely unrecognizable than who I was before pancreatitis. So I just encourage people to reframe your mind, reframe your perception and your understanding of your circumstances, challenge your assumptions within yourself and what you're being told, and just go see what you're capable of. And don't let this thing beat you down. Thank you.
Thank you so much, Matt. You are truly an inspiration to listen to, and we are so grateful that you are here with us today, and that you fought through those extremely challenging times and will continue to. As we know, this is a lifelong battle, but your perspective and your story is so wonderful and is inspiring many. And through the chat, I've been reading the messages of people sharing their own stories. Thank you all for being vulnerable in there and sharing with us as well. And a lot of them can relate to much of what you have shared. So thank you so much for being with us here today and sharing.
So the opportunity.
Absolutely. Thank you, Matt. Well, next up, we have Nicole from the U.S. Pain Foundation, who will be sharing next. Nicole, welcome. I am just pulling up your presentation here. We are so glad to have you with us.
Well, great. Thank you so much. While you're pulling up the slides, first, it's very hard to go after Matt. Thank you so much for having the courage to share your story, your journey, your experiences with all of us. I am so honored to be here tonight. Thank you first, Mental Health America and the National Pancreas Foundation for inviting me to be part of this really important discussion. As a person who has lived with pain for 3 decades and as the CEO of the U.S. Pain Foundation, I truly am humbled both personally and professionally to talk to you all about pain, mental health, and its devastating impact on quality of life. Next slide, please. So first, I thought it would help if I just shared a little bit about the U.S. Pain Foundation. Our mission is to empower, educate, connect, and advocate for all individuals, kids and adults who live with a chronic illness or serious injury that causes pain, as well as for their caregivers and clinicians. And recognizing that nearly every chronic condition has a pain component, our network is very extensive. Next slide. We are deeply invested in helping individuals through our free programs and services. I have a list on this slide that shows our programs, and they range from anything from a national network of support groups that is led by a clinical social worker to advocacy efforts to a pediatric pain program. Our overall objective is really to elevate that patient voice, to increase disease state education, discuss top policy challenges that we're all facing, expand outreach to the underserved and marginalized communities, and provide comprehensive resources that are really going to ensure people with chronic illnesses or serious injuries are supported and empowered along their journeys. Next slide, please. So as we work to help people with pain, we keep in mind some core values that really guide our overall efforts. And I wanted to take a moment to share them with you tonight. We believe that people with chronic pain are underserved, overlooked, and misunderstood, that pain has enormous emotional, social, and financial consequences, not only on individuals and their families, but also society at large, that each person with pain is unique and they deserve an individualized treatment plan, and that patients should have affordable access to all types of treatment. Next slide, please. Last year, US Pain conducted a survey, and it was a national survey to really better understand the public health crisis of chronic pain. Some of the topics that were explored was the types of pain, ability to work, patient-provider relationships, treatment options, and mental health. Respondents included 2,275 people that live with chronic pain, and we defined pain as pain lasting 3 months or more. Next slide. Here are the main findings from the survey, which really align directly with what we as an organization hear every day from folks. And that is that chronic pain has devastating consequences on overall life, that people with pain feel unsupported and stigmatized, that medication still remains the most effective treatment option for most, but that people face significant barriers accessing it. Cost is the primary barrier to pain care, and that multidisciplinary approaches are under-recognized components of effective pain management. Next slide, please. So before we really tackle that intersection of mental health and pain, I wanted to highlight the severity and disability amongst our respondents. Nearly all respondents said that pain has restricted their ability to engage in routine activities. And these activities are household chores, sleeping, being able to work, maintaining friendships and socialization, traveling, intimacy, and so much more. A significant portion also said they consider themselves to be disabled, and more than half of the respondents reported having an average pain level of 7 or more. A total of 24% of folks said that no side effect would preclude them from using a medication if it helped their pain. And the reason I share this is because I find it to be so profound of a stat. We listed very serious side effects in our survey, such as liver or kidney damage, trouble breathing, etc. But the fact that 24% of people still say that no side effect would prevent them from trying a medication clearly depicts that people with pain are desperate for relief and open to whatever options are still available. And another point that I wanted to just call out is that while conditions varied widely amongst our respondents, a commonality was the prevalence of comorbidities. 30% of respondents reported having 6 to 10 comorbid conditions. This is just an enormous figure that really underscores the complexity of the health of this patient population. I'm seeing it in the chat, how many of you are living with multiple conditions and trying to navigate it. And it means that we need better coordination of care. We need better mental health support, and we really need society to come together and make sure we have better health outcomes going forward. Next slide, please. Another area that was explored in the survey was the patient-provider relationship. And unfortunately, our findings show how this fractured relationship is actually adding unnecessary stress, anxiety, and mental health concerns to this underserved population. 59% of respondents said their current provider doesn't sometimes or rarely listens to and validates their concerns. Also, 69% said that they do not, only sometimes, or rarely feel like they are a team with their current provider when it comes to managing chronic pain. And for me, this just solidifies, again, what we are hearing frequently. Patients do not feel heard, believed, or supported by their healthcare professionals. And that is partly why these individuals that are living with such severe pain retreat inward. They disconnect. They feel ashamed to share their experiences, and sometimes even stop seeking help and care. This really needs to change. Next slide, please. All right, so now I really want to take a better look at the findings regarding the intersection between chronic pain and mental health. And you'll see on this slide, first, 79% feel stigmatized because of pain. Nearly 60% said they feel anxiety-like or depression-like symptoms daily or a few times a week. But what was staggering is that despite those numbers, 38% of our respondents reported that their current healthcare professional does not ask about mental health or if they are experiencing feelings of anxiety or depression. This is not all right. These figures really should raise alarm. We see that these are some of the most vulnerable people inside our healthcare system, and their physical and emotional needs are not being addressed. We need to do better. We need to do more to provide support, to provide mental health access to individuals, to validate and recognize the experiences of people that are living with chronic conditions. Next slide, please. Again, and I've been saying this all along, but my team and I hear weekly from individuals who are suffering and struggling. While these folks may be living with different conditions and diseases, there is a commonality in their stories, one being the pain, and the other being the feelings of isolation and grief, of hopelessness and despair. Individuals share with me that they have been denied treatments, they've been dismissed or marginalized, have lost their providers, their homes, their families, basically everything because of pain. Pain impacts mental health greatly. I hear from people who want to attend their grandkids' soccer games, who would just like to go to church on Sunday, who want to make a meal for their families, or even just to receive a hug from their child. And yet pain from their disease or condition has taken that from them. Pain has changed who they are, what they're able to do, how they are able to live. It has robbed them of their independence, their self-worth, which is really why I'm here today. We as a country need to do more to provide support and access to mental health support and care. Next slide, please. So what are we doing to really address mental health at US Pain Foundation? Well, first, we recognize the impact of mental health and pain, and we make sure to highlight informative articles and share much needed resources. But most importantly, though, the organization offers a national network of support groups. The program is called Pain Connection, and it was developed by a clinical social worker who also lives with pain. She then created a specialized curriculum for all of our support group leaders, which means that each US Pain support group facilitator has gone through comprehensive training led by a clinical social worker, and they continue to get training and guidance from her on a day-to-day basis. Our monthly support group meetings are offered online. They are free, and they provide compassionate support and evidence-based education to really help people reclaim their lives. Next slide, please. So US Pain provides 3 different types of groups. They are national, state-based, and special population meetings. National groups are available to anyone with chronic pain, and they typically relate to a monthly theme or topic. We have 1 weekly meeting every single week, and we also have daily check-ins Monday through Friday that anybody can join to make sure that they are being supported and cared for. Our state-based group locations really give individuals an opportunity to find that local community of support and connect with people that live nearby them. And then lastly, we recognize that specific populations within the pain community face unique challenges as they navigate their health conditions. And this is why we provide many different specialized support groups. I have a list of all of them on our slide, but we have some for teens, for caregivers and care partners, for the BIPOC community, the LGBTQ+ community, and beyond. Our main goal is just to make sure that people know they are not alone, that they are understood, validated, and recognized, and that people are here to provide support. Next slide, please. So I just quickly wanted to share our Pain Connection website with all of you. So this way you can learn more about our support groups, you can register to attend one, and also if you are interested, you can always apply for our future chronic pain support group leader trainings. We currently offer them twice a year, and they're being offered virtually at this moment. Next slide. So switching gears slightly, as an organization, a focus of ours is also helping to turn a patient back into a person. Next slide. So what does that actually mean? Well, we are helping individuals find a renewed purpose, to redefine their lives, to find a new normal. And we do this really through our work of creating connection, information, empowerment, and hope. And I want to take a few moments now to talk through some of the ways that we achieve this. Next slide, please. As mentioned earlier, one key finding from our survey was the widely employed use of multidisciplinary approaches, especially activity restriction or modification. We believe that teaching activity restriction, or pacing as we typically refer to it, is an extremely beneficial tool to help anyone along their journey managing a chronic disease, managing pain, managing a serious injury. So we spend a lot of time discussing at length pacing, determining and setting limits and boundaries, as well as other self-management approaches, from mindfulness to meditation to exercise and diet, in our support groups and also in all of our programs. Next slide. As we continue to look at data from our survey, 56% of individuals reported informative articles are the most helpful information to them when they connect with a patient organization. And from our perspective, we really agree. Once an individual is equipped with knowledge, they start to feel empowered. They connect with others in the community. They find support. They branch out. They have confidence and start advocating for themselves and for others. They are now becoming part of the treatment pain plan, and they found their voice again. So ways that we help folks find information and education is through a variety of different services and programs that include timely and educational articles, a monthly educational series where we bring in practitioners to teach individuals a pain management strategy or skill, an interactive site called My Pain Plan, where you can actually explore over 85 types of treatments across 7 different categories of pain management. We have educational resources, webinars for families and adults that can range from looking at clinical trials to how to apply for SSDI or to yoga for pain. And then we spend a great deal of time also looking at awareness initiatives and educational campaigns. And the reason we do this is we want to help remove barriers and stigmas associated with chronic diseases that have a pain component, while also spotlighting just how pain is a disease in and of itself that really must be treated and looked at. And through that, we will be better able to address mental health. We will be able to look at pain and its intersection and hopefully find better health outcomes. Next slide. So one of the final pieces I want to discuss tonight is really regarding the power of our voices. And Matt did such a beautiful job earlier sharing his experiences. Advocacy or advocating is really the belief that we can make a difference and change how people are viewed and treated. And each one of us here today has a unique and important story to share. And the more that we can speak out about the challenges we face, whether it is about access to care, mental health, health equity, the more that we really can help remove stigma and improve health outcomes. I am such a firm believer in the power of our voices and our lived experiences. And it really is those lived experiences as constituents that directs change. We hold the power, and together we are stronger than ever. It is you, it is your experience, it is your unique voice that makes a difference and truly, truly matters. And so I just want everyone to know that they are never alone. We at US Pain are here with you, along with everybody else that's actually on this panel too. We are advocating alongside you every day just to make sure that each of us has the resources, the support, and access to care that we need and deserve. Next slide, please. Okay, so that is me just wrapping up, but I just want to say to close, thank you again for giving me this opportunity to talk about pain, mental health, and the programs. I am so passionate about this, being part of this pain community. I'm very passionate about looking at mental health, removing those stigmas, making sure that people know that there are resources and information and support out there for them. So for anyone who wants to learn more, I invite you to visit the US Pain Foundation And again, thank you so much to MHA and NPF and everybody else on this panel for giving US Pain this opportunity to participate. It's a much needed discussion, and I hope we continue to have more conversations about it.
Thank you so
Thank
much,
you.
Nicole. We are so grateful for you joining us here tonight and the really wonderful information you shared with us all. It is so great at MHA to hear the work that you are doing at the US Pain Foundation and your commitment to patients and really understanding not only the physical challenges they're going through with pain, but the effects that has on your mental health. And I know so many of you, thank you again for sharing your stories in the chat and being so honest and vulnerable with us all. I was reading through them all, and it really is so touching to hear each of you connect with each other and speak out about your own experiences as well. And I know, Nicole, you were presenting, so you probably couldn't check in there, but many were echoing the sentiments that you were sharing. And just like we talked about with Dr. Wasif and Matt coming afterwards, is we see these statistics, but there's people behind the statistics. And the people are people like Matt and those of you that are joining us here tonight that are sharing their stories. And that advocacy is so important that you shared at the end, and something that we talk about at Mental Health America constantly, of breaking the stigma of feeling alone and ashamed of what you're going through, and being able to share that and be open and ask for help, and help is available. And many were inquiring about those support groups that you have, Nicole. So I added that link to them in the chat, and we'll also include that information in the follow-up material for you all too. Thank you, Nicole. Well, to wrap up tonight, we have one more presentation with Dr. Ulrich. We are so excited to have you joining us here tonight. I am just pulling up your slides, and I will let you take it away.
Okay, I don't know how much time you have left. I had 3 minutes. Is that right?
You have a full 15 because we are an hour and 15 for this session.
Oh, okay, good.
Yeah.
All right. Well, let me start off with saying that my experience with cardiac disease started 28 years ago. So I've been dealing with atrial fibrillation had 5 pacemaker changeouts. 2019, I suffered a sudden cardiac arrest, and that was essentially, I was dead on the floor in a restaurant for probably about 5 minutes before they got me started again. And when you talk about, so I've spent the last 4 years involved in research in an area that is fairly well ignored, called cardiopsychology. You talked about, the others had talked about medical professionals not being not much of a bedside manner, not really caring much about them. 82 million people have cardiovascular disease in this country. There are 33,000 cardiologists. If you divide that out, and given the number of work hours in a day, that means that each patient is going to get about 5 minutes of a cardiologist's time. And when it comes to the mental health side of the issue of cardiology, most cardiologists, I'm afraid to say, are not very well schooled in it, and B, not very interested in it. So go ahead and do the next slide. So these slides are going to carry you through a program that I developed to address this. Once people have a cardiac event of some kind, they're going to never be the same for a number of reasons. You want to use a soundtrack for these or no? You want to use a
I tested out our sound and it doesn't look like it is coming through. So if you can just narrate for us, that would be great.
All right. Well, I can do that. I've got the script that I use to make these anyway.
Thank you.
Essentially there's two different types. So one's called a cardiac arrest, which is actually a myocardial infarction, and the other one is a heart attack, which is what I had, which is a sudden cardiac arrest. In the case of a myocardial infarction or heart attack, you have reduced blood flow, but in the case of a sudden cardiac arrest, you have zero blood flow. So that means that the brain, which is lives and and dies on oxygen-enriched blood, is not getting fed. Ergo, you've got about 5 or 6 minutes before serious things start happening. The slide, please. Okay, one of the biggest things that people find is that about 60% of the patients have a memory loss. And there's two kinds of memory. One's long-term and short-term. In the short-term area, that is something that you can try to compensate with. I carry a little notebook with me everywhere I go. I have memory loss. And when I think of something I want to do or need to do, I'll jot a note down. And that can be a real help for an individual, particularly because you feel bad when you can't remember something that you're supposed to remember, particularly if you go to the store and you say, well, what was I supposed to buy? The other thing is the long-term memory is where you get into back to the overview, where you get to forget somebody's name, a good friend that you've known for years, and all of a sudden you can't remember their name. Two different parts of the brain are affected in that. I'm not going to go into it. Go ahead and change the slide. There we go. Okay. So memory disorders can be very difficult to deal with. You feel like you've really lost quite a bit. Blueberries can help. There are things you can do to compensate for that memory loss. Change the slide, please. There we go. Okay. But one of the big things that you can do is be careful about developing what are called negative neural networks. You start thinking about things, and the depression sets in, and anxiety both, and you start spiraling down because you start adding more and more and more of these things that you're now limited to do because of the cardiac event. Slide, please. Okay, and the one thing that tends to be, start thinking about the same things over and over again, ruminating, if you will, and that just complicates things and keeps making your life more miserable. So people need to grab a hold of this repetition, stop it immediately as soon as you feel it coming on. Slide, please. Okay. Cardiac events cause stress. You've heard people talk about stress in previous presentations. Stress can be dealt with. Stress is not something that you have to live with. The ability or inability to resume a normal life is going to cause stress, and it's going to cause changes in relationships. Slide, please. Here are some things you can do to manage stress, but again, they're short term. You need to be very careful about some of the things on the left side, particularly the smoking and the drinking side. But and there are things that prescriptions that can be given, but quite frankly, they're very short term. They're not anything that you need to take for 2 or 3 years. Really, it's a matter of weeks and months. Slide. The best way to deal with stress is to find some other non-medical ways. And one of the things we found is that animals, particularly, well, dogs and cats both, but I guess it could be guinea pigs too, just by stroking their fur will reduce your blood pressure. And when you do reduce your blood pressure, you're really putting your body in a much better place. Slide. The other thing is having someone that you can talk to, that you can You can laugh with somebody, that a good friend, either an old one or make a new one. The result is you have a relaxed feeling. Slide. Again, this is good. I'm a psychologist, so I'm talking myself out of a job. And this is true. If you had a good friend, you wouldn't need a psychologist. Slide. Laughing is another thing that's very much underrated as far as relieving stress and also addressing depression and anxiety. So if you can find somebody, and particularly an individual that has a good sense of humor, that's money in the bank. Slide. Another thing I have found I started writing almost immediately when I got out of the hospital, and I've written I don't know how many short stories and essays and whatnot. And I found journal writing or just writing in general, expressive writing, is very valuable in reducing stress. Slide. Writing about emotionally charged subjects can also improve your mental health, as the slide says. I don't need to read it to you. The major depressive disorders are classic in sudden cardiac arrest and in heart attacks as well. Slide. If you have had a religious tradition and kind of fallen by the wayside with that, you might re-explore it and see how that theology that you discarded years ago fits now. Slide. Weight's a problem because you feel like you can't. In fact, you in many cases you're asked not to exert a lot of, particularly if you've had surgeries of some kind, not to exert yourself physically, but you really do need to get into a program where you are exercising in a acceptable way. And generally, most hospitals and clinics, I suspect, have a rehabilitation program where you're gonna go in there, you're gonna do some exercise, they're gonna monitor you the whole time. I think the program I did was like 2 months, and it was really, really worthwhile. Slide, please. But on the other thing, the other side of that is because you're not as physically active as you were, you're still eating at the same level, and that's where you start putting on weight. Meditation is another thing, and I've tried it, and it works well for me. We're going to talk about Tai Chi, I think, in a minute. That's what I used. Yoga is another one. Slide. Prioritize positivity. Seek to find the things that are an affirmative, affirming you, affirming your life, affirming your family, instead of things that are negatives. Slide. Sleep apnea. It gets a lot of play on the news lately. Well, advertising mostly. But if your cardiologist suggests that you have a sleep apnea test, take them up on it, because one of the things that happens is your heart actually can repair itself while you sleep, but you have to have good sound sleep before it will occur. And many cases, people sleep apnea prevents them from having that. So I have a sleep apnea machine. It's called a BiPAP machine, and it works great. Thank you. Slide. The psychologist will be able to deal with and determine a number of things using what are called instruments, particularly easy to diagnose depression, anxiety with pencil and paper instruments are called. And what that does is will focus your efforts to improve your life, starting out with some one-on-one psychotherapy, and then moving on into other areas. Slide. Now, the other thing for stress reducers that's great is do something with your hands. You can see all the things that are on here that are possible. What I have found that works for me is doing needlepoint. And so I started doing needlepoint some years ago and find it very relaxing, very soothing. Slide. I have a program in guided imagery. Guided imagery is a process. I took the course some 20 years ago, but I still like it. I think it's an excellent way for people to visualization is what it's about, to put yourself in a place where what will happen is that your mind will allow your body to slow down, which is going to slow, of course, your heart rate. And then that's gonna put you in a much better mood. And you can do this. It's easy to do 2 or 3 times a day. Sometimes you don't have to spend more than 15 or 20 minutes doing it, and you'll be amazed at how you feel afterwards. Slide. Start out with guided imagery, usually with a psychotherapist who will lead you through it, teach you how to do it, and perhaps even in a group. Group therapy is great, and then ultimately you can do it on your own. Slide. Again, you need to, guided imagery is not faith-based. That's one of the things that some people are not interested in going down the road with a religious type of therapy. And this is not, guided imagery is not faith-based at all. Slide. Okay, so knowledge is power. Old Francis Bacon, nothing like a good Englishman. Survivors of traumatic injury learn about the overall effect of having experienced a cardiac event. That is that you are the survivor. That's the best part. The cognitive deficits that you can come up with on this can be addressed. There are ways to deal with them. Slide. Okay, so realizing you're not alone is also one of the big things. Sometimes you feel very isolated, particularly if you're just recently after the event, and you feel like you're the only one in the world that's gone through this. Of course, you have, but developing the skills to improve your memory, deal with the stress, the other deficits, as well as your life with others is the way to do it. Take a positive approach. Slide. So these are the things you want to include: memory and what to expect in a post-event, keeping track of things, writing them down, keep a little diary, dealing with stress. There's a whole toolbox of things you can do there. Hand and mind, really need to keep your hands busy doing something, whether it's woodworking or crocheting, knitting, whatever, painting is all possible. Relationships, you need to tend to your relationships, because frequently family and friends are going to be your caregivers, and that's going to be a new thing for you. Anger, very, very difficult, because you're feeling so bad about the idea that you can't remember somebody's name, or that a sudden loud noise causes you to have an explosive outburst. Very common with following a cardiac event. Slide. Okay, that looks like it might do it then.
Thank you, Dr. Ulrich, for that presentation. We appreciate your area of expertise within the cardiac conditions that many Americans experience. I know those were some really helpful tips for different things that people can do. And I saw in the chat some people relating to things such as having pets that they love that calm them down, doing yoga, Tai Chi, journaling. All of those things are so important to remember in recovery of any kind. And that's kind of across the board of the different chronic diseases and chronic pain conditions that we've looked at tonight. So thank you. And I know we are just at the end of our session here, but I want to wrap up by saying thank you so much to each of our panelists who shared here with us tonight. Each of your perspectives from the background and knowledge that you have, and thank you to Matt for sharing your personal experience with us tonight. I know so many people that were joining us here tonight also had that personal experience to share. So thank you all for joining us tonight for this session. Just a reminder, we will send out a follow-up that will include the recording of this session along with some of those resources that were posted. A big thing that I took out of tonight is the importance of support. And I saw so many of you supporting each other in the chat throughout tonight, sharing. And that's one of the things that Nicole had discussed too, is that importance of community and support throughout your recovery journey. And there's some really great resources she presented with that we'll also share with you. So thank you all so much for being here tonight. We thank NPF for their partnership with us, and stay in tune to MHA and NPF's announcements, because like David shared, we will have more of these to come throughout the next year and continue these important discussions. So thank you all. With that, everyone have a wonderful rest of your night. Thank you.